Welcome to the deep dive. Let's just jump straight in.
Huh.
In England and Wales, breast cancer diagnoses are, well, quite high, around 40,500 women each year,
Mm-hmm.
and about 260 men too, which is less common but still significant.
Absolutely.
And the tough part is, for some people, that diagnosis comes when the cancer is already advanced, stage 4.
That's right.
So for you listening, this deep dive, it's really about understanding the care, the support,
Hmm?
what's available now for people facing that. And we're basing this on a really solid source.
Yeah, we're looking at the NICE guideline. It's specifically on advanced breast cancer diagnosis and treatment.
NICE being the National Institute for Health and Care Excellence.
Correct. And this guideline is really current. It was updated just February 2025. So it's based on the latest evidence.
And what's its main goal?
Well, fundamentally, it's about helping patients and their doctors make decisions together, share decisions about tests, treatments,
Right.
all aiming to improve outcomes, not just living longer, but, quality of life too. And it pulls from loads of different research.
Okay. And for you listening, maybe you're here for personal reasons or supporting someone, or maybe it's for your work.
Mm-hmm.
This deep dive is really designed to pull out the most important bits from that guideline, give you a clear overview, but without drowning in detail.
It's sort of a shortcut to getting informed on a complex topic.
Exactly. So
Yeah.
our mission today, we're going to explore the key recommendations.
Yeah, we'll cover diagnosis, how information and support should work, the treatment options, both systemic ones and managing complications.
And we'll even look at what research is still needed.
Right. The idea is to equip you with that essential knowledge about how advanced breast cancer care looks today.
Okay, let's unpack this, starting right at the beginning. Diagnosis and assessment. The guideline gets pretty specific about imaging, doesn't it?
It does, and it's quite nuanced. For checking if cancer has spread to internal organs, visceral metastases, we call them.
Like liver, lungs.
Exactly. They recommend using a mix. Plain X-rays, ultrasound, CT scans, MRI, each gives a slightly different piece of the puzzle.
And what about bone spread? That's quite common, unfortunately.
Very common. For bones, they talk about using CT scans with special bone windows, basically settings to see bone clearly, or MRI,
Okay.
or a bone scan, which is also called bone scintigraphy. That gives an overview of the skeleton.
And you mentioned something about checking specific bones if they're spread elsewhere.
Yeah, that's an important point. If cancer is found in bones somewhere, they recommend specifically checking the upper arm and leg bones, the proximal limb bones.
Near the shoulder and hip.
That's right. Using a bone scan or X-rays just to check the risk of a fracture there. It's about being proactive.
Preventing problems before they happen.
Exactly.
Now, you mentioned MRI. Is there a specific time when that's particularly useful for bones?
Yes. The guideline suggests MRI if other scans are a bit unclear or if they need a really detailed picture.
Like near the spine?
Precisely. If there are metastases, breaking down bonolytic metastases near the spinal canal, MRI gives that extra detail.
Got it. And what about PT-CT scans? Are they used much at the start?
Generally, no, not for the initial diagnosis of metastases. The guideline says only consider it if other scans are suspicious but not conclusive, so it's not usually the first port of call.
Okay. Moving beyond imaging to understanding the cancer itself, there's a key point about retesting the cancer.
Absolutely crucial. The guideline recommends considering rechecking the ER and HER2 status if the cancer comes back or spreads.
So rebiopsying.
Often, yes, because, and this is fascinating, the cancer's characteristics, its receptor status, can actually change over time.
Really? Like I know that.
It's a key thing. And
Yeah.
if that status changes, it can completely change which treatments are likely to work best. It could be a game changer for the treatment plan.
Wow. Okay. And when it comes to monitoring treatment, especially for bone metastases, is there anything the guideline says not to use?
Yes, it's quite clear on this. It advises against using bone scans, bone scintigraphy, to see how bone metastases are responding to treatment. They aren't always reliable for showing response in bones. Sometimes healing can look like progression initially. And similarly, it advises against using PT-CT for general monitoring of advanced breast cancer response.
So sticking to the recommended methods is key.
It avoids potentially misleading information.
Okay. Now, obviously, getting this diagnosis is huge. The guideline really focuses on information and support for decision-making, right?
Massively. It's a core part. They stress assessing your preference, the patient's preference for how much info you want and what type.
And that might change.
Exactly. So doctors should check back in regularly. What felt right at diagnosis might be different later on, needs change.
Makes sense. It's about consistent, relevant info, clear explanations.
And always, always giving opportunities for questions. It sounds simple, but it's vital.
And that ties into shared decision-making.
Directly. The guideline says healthcare teams need to understand how involved you want to be in decisions. Again, it varies hugely.
Some people want all the details, others prefer the doctor to recommend.
Precisely. And the guideline mentions using decision aids.
What are those?
Tools, basically. They can be leaflets, websites, videos, designed to help you understand options, weigh pros and cons, and figure out what matters most to you.
Right, aligning treatment with personal values.
That's the goal.
Okay, let's shift to treatments that work throughout the body, systemic therapy. For ER-positive cancer, which is common, what's the usual first step?
For most people with ER-positive advanced breast cancer, the first recommendation is endocrine therapy.
Hormone therapy.
Exactly. Treatments that block or lower estrogen, which fuels these cancers.
But isn't there an exception?
Yes, a really important one. If the cancer is growing very rapidly, is immediately life-threatening, or causing severe problems because it's spread a lot to vital organs.
Significant visceral involvement.
That's the term. In those urgent cases, they might offer chemotherapy first, even if it's ER positive.
Because chemo works faster.
Generally, yes, it can shrink things down more quickly in an emergency, and it's a big but. The patient needs to understand and accept the side effects.
And then maybe hormone therapy afterwards.
Yes, the guideline recommends offering endocrine therapy after the chemo is finished in those situations.
Okay. Now, within endocrine therapy, it gets quite specific based on, like, menopause status and previous treatments.
It does. For postmenopausal women with ER-positive cancer, they recommend an aromatase inhibitor. That applies whether they've had hormone therapy before or not.
Aromatase inhibitors. Non-steroidal or steroidal?
Either type. For premenopausal or perimenopausal women who haven't had tamoxifen before, the first choice is tamoxifen plus ovarian suppression.
Ovarian suppression, like injections.
Usually, yes. Or sometimes surgery. If those women have had tamoxifen and the cancer progresses, then ovarian suppression alone is recommended.
And for men?
For men with ER-positive advanced breast cancer, tamoxifen is the first-line recommendation.
Right. Now, what about chemotherapy beyond that urgent situation we mentioned?
For most patients choosing chemo as their disease progresses, the guideline suggests sequential therapy.
Meaning one drug after another.
Exactly. Use one drug, see how it works. If it stops working, move to the next. Single agents, usually.
Rather than combinations straight away.
Right. Combination chemo might be considered if getting a response quickly is really critical, and importantly, if the patient is well enough to tolerate the likely increase in side effects.
Okay. And are there specific chemo sequences recommended?
Yeah.
Especially if someone can't have certain drugs like anthracyclines.
Yes. For patients unsuitable for anthracyclines, there's a suggested order. First line, docetaxel.
Okay.
If that stops working, second line, either vinorelbine or capecitabine.
Either one.
Either one. Then, third line, whichever of those two wasn't used second. So if you had vinorelbine second, you'd have capecitabine third, and vice versa.
That's quite specific.
It provides a clear pathway. There's also a note about gemcitabine with paclitaxel. It's an option, but only really when docetaxel options are also appropriate, considering the drug licenses.
Right. And finally, under systemic therapy, what about biological treatments like trastuzumab?
Trastuzumab targets the HER2 protein. The guideline says if you're on trastuzumab and the cancer only progresses in the brain or spinal cord, the central nervous system.
Keep taking it?
Yes, continue trastuzumab. But if the cancer progresses elsewhere in the body, the advice is to stop it.
And other biologicals or targeted therapies?
They're often covered in separate NICE guidance. The guideline points people to the main breast cancer topic page on the NICE website for more on those.
Okay, that makes sense. Now, beyond treating the cancer directly, supportive care gets a big emphasis.
Huge. The guideline is really strong on this. It says services must align with NICE overall cancer service guidance.
Which means?
It means routinely assessing and talking about all sorts of needs. Physical symptoms, psychological well-being, social support, spiritual aspects, even financial worries.
At key points in the journey.
Yes. Diagnosis during treatment, if it comes back towards end of life, it needs to be ongoing.
And it mentions continuity of care, like having one main contact.
Exactly. Mechanisms for continuity, possibly having a designated key worker, someone to help navigate the system, coordinate things. It's about that holistic, joined-up care.
Okay, let's talk about managing specific complications. Lymphedema is one, arm swelling.
Interestingly, the specific advice on lymphedema that used to be in this guideline, it's actually been stood down.
Oh,
Because another nice guideline, the one on early and locally advanced breast cancer, was updated more recently in Feb 2025, and that now covers lymphedema management, risk reduction, the whole lot.
so the advice is still there, just in a different guideline.
Exactly. Shows how things evolve.
What about cancer-related fatigue? That affects so many people.
It does. The guideline says anyone significantly unaffected needs assessment to find treatable causes.
Like anemia or thyroid problems.
Things like that, yes. Manage those if found. Provide clear written info about fatigue itself, and importantly, details of support organizations.
And exercise.
Yes, information about exercise programs and making sure there's timely access to them. Activity can really help manage fatigue.
Good to know. What if the cancer causes problems locally, like on the chest wall? Uncontrolled local disease.
The guideline recommends assessment by the full breast cancer multidisciplinary team, the MDT.
To discuss options.
Yes, options for controlling the local disease and relieving symptoms. It also mentions involving wound care specialists, especially for fungating tumors where the cancer breaks the skin.
And palliative care.
Absolutely. Palliative care teams should be involved to help develop symptom management strategies and provide psychological support.
Okay. Bone metastases, and again, we talked about diagnosis, but what about managing them?
Key recommendations here. First, consider bisphosphonates for anyone newly diagnosed with bone mets.
To strengthen bones and reduce pain.
Exactly. Prevent fractures and help with pain. The specific drug is usually a local decision based on guidelines and patient preference. For pain relief, single-dose radiotherapy is recommended 8 gray.
Just one treatment?
Often, just one fraction can be very effective for bone pain. And if there's a risk of a major fracture in a long bone, an orthopedic surgeon should assess for preventative surgery.
Prophylactic surgery.
That's the term.
And finally, brain metastases. How are they managed?
It depends on various factors, number of metastases, whether they can be removed, overall health, other disease control.
So it's complex.
Vary. But generally, if there's a single or few resectable mets in someone otherwise, well, surgery followed by whole brain radiotherapy is recommended.
And if surgery isn't an option?
Then whole brain radiotherapy is the usual approach, unless the overall outlook is very poor. And crucially, after treatment, active rehabilitation is important.
Rehab to help recovery.
Yes. And if active treatment isn't appropriate, then referral to specialist palliative care is key.
It really covers a lot of ground. Okay, let's switch gears slightly. The guideline also points out where more research is needed, right?
Yes, and this is really important. It shows where the knowledge gaps are, where future efforts should be focused.
What are some of those areas?
Well, one is about lymphedema, again, specifically looking at the role of arm and shoulder exercises. How effective are they compared to standard treatments?
More evidence needed on exercise.
Yes, proper trials, looking at long-term effects. Another big one is about the best sequence of endocrine therapies for postmenopausal women whose ER-positive cancer progresses on an aromatase inhibitor. We need trials to compare different sequences.
So which hormone drug should come second or third?
Exactly. We need better data on that.
What else?
Chemotherapy sequences. Similar question. What's the most clinically effective and cost-effective order to give different chemo drugs? Surprisingly little high-quality evidence there.
Really, despite chemo being used for so long.
It seems so for the optimal sequencing. Then there's the question of continuing trastuzumab if HER2 positive disease progresses outside the brain. Should it be continued or not needs more evaluation.
Okay, two more.
Fifth is about using further biological therapies for patients whose cancer becomes advanced after they've already had adjuvant trastuzumab for early disease. As more people get adjuvant trastuzumab, this is becoming a more common question.
Right.
And finally, managing uncontrolled local disease. It's poorly understood. The guideline calls for more research, maybe even setting up a national register to track cases and outcomes better.
Fascinating to see where the frontiers are. Just to circle back and give that context again, the scale of breast cancer?
Yes, it's the most common cancer in women in England and Wales. Those numbers again. Around 40,500 women diagnosed yearly, about 10,900 deaths.
And for men, about 260 cases, 68 deaths annually.
Correct. And while only a small percentage are diagnosed at stage 4 initially.
Many others develop advanced disease later, after initial treatment.
That's right. Recurrence or metastases happen for a significant number.
And this guideline is trying to bring consistency to managing this complex situation.
Precisely. There have been lots of advances, new drugs, better understanding, but practice has varied across the country. Treatment availability hasn't always been consistent.
So the guideline aims for best practice everywhere.
That's the goal, standardizing high-quality care.
Okay, so as we wrap up this deep dive into the NICE guideline, what are maybe one or two key takeaways for listeners? Things that really stand out?
I think one is definitely that dynamic nature we talked about, remembering that the cancer itself can change like the ER sure status, and that means treatment needs to be adaptable.
It's not static.
Not at all. And the other huge takeaway for me is the absolute focus on the individual. Shared decision making, understanding your preferences for information, for involvement, it runs right through the guideline.
It's about partnership between the patient and the healthcare team.
Absolutely.
Well, hopefully this has given everyone a clearer picture of how advanced breast cancer care is approached, based on these expert recommendations.
And remember, the full guideline is on the NICE website. If you want all the detail, it's there, along with tools for healthcare professionals, too. It's a valuable resource.
Definitely worth exploring further if you need more specifics. So, thinking about the future and all that research that's still needed on exercise, on treatment sequences, it really makes you think, doesn't it? How might care become even more personalized, even more effective down the line to improve life for those living with advanced breast cancer? Thanks for joining us for this deep dive.